Good morning, everyone. I am Dr. Francesco Martinetti, an orthodontic specialist, and I am pleased to share with you this innovative technique called Palatal Sagittal First. This approach always uses sagittal correction as the first step, and the clinical case we presented has also been published in the Journal of Clinical Orthodontics under the title Modified Class III Carriere Motion Appliance and Aligners for the Treatment of Class II Malocclusion. In other words, we are satisfied with the Class II Carriere Motion, but it does have some side effects, sometimes even quite significant ones. These include extrusion of the canine if the Carriere Motion is bonded, attached to the upper canine, and conversely, it also causes intrusion of the molar where it has been bonded. As you can see from the images, at the end of the correction with the Carriere Motion, in the first 6 months, I achieved a class correction, but also ended up with extrusion of the canine and intrusion of the upper first permanent molar. Additionally, there is also increased mobility of the canine or of a premolar if I place it on the first premolar with the intrusion. Another side effect is not just intrusion and extrusion, but also a contraction of the upper arch. So I have a contraction of the 6th. You can see before or after the tooth, the 26th, how it has contracted significantly, and since it's on the outside, you can also see this little bar from the canine to the 6th is visible, so aesthetically it's somewhat noticeable. Again, other practical disadvantages of the Carriere Motion are also that after the 6 months when I remove it, I have to wait for a month on standby. For what purpose? To then reprogram the second set of aligners or to cover the lab cost of the upper printed metal tray. Because during this month, nothing should move, otherwise the following trays won't fit anymore. And then, when the next set of aligners arrives for the second phase, I have to place the attachments on the upper premolars and molars. So, given all these issues, what did I come up with? We considered placing the Carriere Motion on the palatal side so that it wouldn't be visible, making it invisible, and starting simultaneously with the aligners, with all the attachments already placed during the first visit, and the Carriere Motion not as a Class II, but as a Class III device. Why? Because the Class III version doesn't have the rotating ball. If I place it on the palatal side, the ball would rotate outward, causing a distal rotation of the molar, which is advantageous. But if I place it inside, it would cause a mesial rotation, which I don't want. So if I attach the Carriere to the first molar, I attach it in this position, and I don't rotate the first molar. Otherwise, I would have to derotate it later. If instead I want to achieve molar rotation, I will attach the pad not on the 6th but on the 7th if I have the space. And you can see that the elastics are placed from the hook on the inside to the 4th, so they need to be attached from the first premolar to the first molar or second molar, and you can see that these elastics go from the inside to the outside. And you can see here instead, this is another case where I attached the Carriere Motion third from the first premolar to the second molar, okay? So that during the distalization movement, at the same time as with the aligners, I can also derotate the permanent molar with the aligner. And you can clearly see how the spaces open up, especially in this case it was more unilateral. It opened up more on the side where I needed it most. What's the concept here? The concept is that the Carriere Motion is like the train that distalizes the upper part, while the aligner is the track along which the movements follow. So it helps reduce side effects, such as the extrusion or intrusion of the premolar, because these are controlled by the fixed attachments on the outside. This either prevents or reduces them. There might still be a bit of a side effect, but only to a certain extent. The big advantage is that Class II cases usually have very constricted upper arches. So the elastic, as you can see, goes from the inside at the 4th tooth to the outside. This elastic helps expand the upper arch, which is something I achieve especially in the first 6 months, so it's very advantageous. So in cases where there is a very narrow V-shaped palate, the Carriere Motion on the outside tends to contract more, or especially if I have cross bites, it's advantageous to place it on the outside because it really provides expansion. It expands both the 4th and the 6th teeth and actually widens the arch. I need to be careful in cases where there are buccal recessions in the palate, so I don't want any expansion, and it will be up to us to evaluate the case precisely. And I will always continue with F1 elastics for the first month, then F2 elastics from the second month onward. And this is basically the case Clearly, this isn't a very pronounced class 2, but rather a neutral molar and canine class. However, you can see a very increased overjet with ectopic buccal canines. From the panoramic x-ray, I can see that the wisdom teeth are very high, so I can leave them in place to allow for distalization. This is the first class that I esclerose because it's mesiofacial. But why? Because the Carriere motion in adults works at the dentogingival level, whereas in adolescents, where there is growth, it actually helps to advance the mandible a bit. This is a bit of the ClinCheck, where you can see how the simultaneous movement of the aligner is simulated, which also mimics the movement of the Carriere motion that is mounted, and then as the final movement, the upper incisors are aligned and distalized. As you can see, the entire initial planning is done right from the start with all these aligners, where in the first 24 aligners, I will either grow the gum or add bracket cutouts depending on the brand you use to bond the Carriere motion inside. Then after the 24th aligner, the aligner is removed. From the 25th, the shape already changes and it covers the surface again, and the entire surface is distalized, but from then on, only the anterior segment is distalized. What is the advantage? The advantage is that I speed up all the movements. In the first 6 months, I don't just do the sagittal first approach, meaning upper distalization and also lower mesialization, but I also expand the upper arch. So I'm already creating space, and with the aligner in front, I'm already aligning the front teeth, especially in class 2 and division 2 cases, where there's a deep bite with retroclined upper incisors. So I carry out the first part of the movement, and you can see after the first 6 months, with the Carriere motion plus the aligner, the classic spaces have opened up between the canine and premolar. This means that the upper distal segment has moved back and the lower segment has mesialized a bit. We've already improved the deep bite and we've already made significant progress. The canines, which were all high and ectopic, have already returned to their proper position. And then, with the subsequent aligners, what did we do? We moved the upper incisors back and aligned them. Here you can see, after 18 months, how we've corrected the molar and canine class, the alignment, the deep bite, and a final refinement was added to give the teeth one last overall alignment adjustment. So, to recap, the class 3 Carriere motion is placed from the first premolar to the molars, or to the first molar. Ideally the second molar if I have enough space, because sometimes there's not much surface area. Sometimes I have to slightly trim the 24 aligners where the premolar pad is because there's little space to attach the pad. Just the standard fit isn't enough, so you need to try and see. The advantage of the attachments is that they're all placed from the beginning, so I don't have to put any of them on a second time. The elastic goes from the lower button on the molar, on the 6th or 7th, to the front pad of the class 3 Carriere motion. Why is this rigid bar important? Because the rigid bar during distalization helps prevent the bowing effect. If you only use the aligner to distalize everything at once, it bends and flexes, much like a climbing shoe where the foot goes from being straight to curling up. As a result, I lose anterior torque, the premolars intrude, and I lose this effect. Instead, the rigid bar gives me bodily distalization of the molars and premolars. The disadvantages. Let's see, what are the main drawbacks? Well, it's a bit more difficult to attach on the inside compared to the outside, especially if I'm bonding it to the 7th tooth at the very back. And it's also a bit harder for the patient to put the elastic on the inside compared to the outside, but they manage just fine. And sometimes you need to adjust the aligner around the fourths because sometimes it doesn't fit well with the Carriere motion. What is the advantage of the rectangular attachments that we already place on the outside? It acts as an anchor, it creates moments on the attachment, and so I always apply distal tip movements to the roots of the molars to avoid tip back of the crowns, aiming to achieve as much bodily movement as possible of the premolars and molars. And this is possible also thanks to the buccal attachments, so Carriere motion on the inside, buccal attachments on the outside. The advantages are that it is indicated for posterior crossbite, so the Carriere motion expands the arch in the back, allowing me to simultaneously correct the crossbite and preventing the arch from contracting any further, which is very advantageous. It is especially beneficial for upper arches that are very constricted, which is the case in most class 2 malocclusions. And it works very well for class 2 and division 2 cases with deep bite, where the upper teeth are retroclined. The full coverage aligner distalizes the back teeth, but as a reaction force, it pushes and proclines the upper incisors already within the first 6 months simultaneously. Why? Because if you only use the aligner in the front, from canine to canine, or even worse, from lateral to lateral, it just does some rough alignment, but it doesn't achieve this nice bodily movement. In Class 2 Division 1 cases, of course, we'll see that it doesn't further proclinate the incisors unless they're already very proclined. It's very advantageous because it reduces the side effects of the Carriere, which are extrusion of the canine and premolar, intrusion, and arch contraction. Why is it a time saver? Because I don't have that standby month where I also have to make the thermoformed appliance, so it's a double practical advantage, saving time and saving on the thermoformed appliance. The disadvantages can be that it's a bit more difficult to design at the beginning because we have to plan all the simultaneous movements of distalization and the concurrent movements of the Carriere with the aligner. However, if you're interested in attending the course or writing to me, we'll take a good look at how to properly set everything up and handle the planning. It's a bit more difficult to place the elastic inside and it requires a bit more manual dexterity. Why? Why? Because the soft carrier at the front needs to be slightly shaped to glue it inside. In other words, you have to take the measurement and then you'll see there's this flexible part where the S is, and that's where I shape it a bit so that the base comes into contact with the palatal surface of the molar. So I can take a tweed plier or a double plier and slightly bend this part, which is flexible anyway. Or I take a tweed plier and shape it. You see, with your thumb you can bend and shape the base well, especially the distal one, less so the mesial one. And then we glue it. You can see a bit of the before and after. You see, it can also be used in asymmetric palates, where one part is all mesialized compared to the other, and with a system of greater forces on this side, you can see that the incisors are all shifted to this side. Notice how I symmetrize the palate during the first 6 months together with the aligners. And then afterwards I will move the incisors and canines to close the space and recenter the midline. You see, this is with aligner number 1 and aligner number 26. In this case, the treatment is still ongoing, so I don't have any final records yet. So you can see how the arch is expanding. Look at how the 6th tooth was contracted and see how it has already been expanded. And also, if I bond it to the 7th tooth, it allows me to derotate the molars as well, so it offers many advantages at once. With expansion, here on the lower arch, if you expand the upper with the elastic, you lose the counteracting forces below, which can cause a contraction of the lower arch. So you see here like this, what is it that I haven't provided? First, I already have the effect with the 3D carrier being a bit loose, which caused the 7th tooth to derotate slightly because I didn't place, as you can see, the attachment. So that was my mistake, and it could have been avoided in the first phase. But, so be careful. At the same time, if you expand the upper arch, you need to apply a counter expansion force and uprighting at the level of the lower premolars and molars to also expand the lower arch. So I have the advantage that by expanding the lower arch as well, I create space to then align the lower incisors in case they are crowded. Here's a question that might come up. What happens if the patient doesn't wear the elastics or even the appliances, or even worse, only puts on the aligners or only the elastics? Isn't it possible that, especially in Class 2 Division 1 cases, the elastics, or rather the incisors, which are already proclined, end up being proclined even more because I lose the anchorage provided by the elastics? You see, in this case, if the patient doesn't wear the elastics, the aligners, you see, they don't fit, they don't seat properly. And in this case, what did I do? You keep going, you don't stop. You put the aligner on the lower arch, you keep using the elastic, and on the upper arch, you stop using the elastic until I've corrected the class. Then I stop, I'll do the scans, and start again. In this case, I'll proceed as with the classic Carriere technique if the patient doesn't wear the elastics. And then the main advantage I get with the aligner in Class 2 cases, look, this is another case where there was a Class 2 only on one side, so I only had to distalize on one side, and there was an anterior block with crowding. In the first 6 months, I already started to procline and relieve the crowding, so I didn't wait for the following months or the 6 months when I would remove the Carriere, so I start right away with the accelerator to save time. You see, these are already the first months. You can see the pronounced anterior block, and you can see how I'm already starting to break through that anterior block. So in class 2, division 2 cases, in my opinion, this system is truly ideal. Alright, this was just a bit of an overview. So if you have any questions, write to me, contact me. We can meet at the course where we go over these topics in more detail. I wish you a good day. Goodbye.